Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Balada from Roots Community Health Center, reporting for the week of October 23rd, 2023. After a COVID status update, I will provide some updates around long COVID research. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. COVID is still with us. It is still causing sickness, disability, and death, and there is still a lot we don't know. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Starting off with wastewater, I will point us again to the decreasing number of COVID wastewater testing sites, which is depicted there with that black line. And I'm going to show you here on the site itself. So at one point, as you can see here, we were up to 1,378 number of sites reporting. That's at the bottom of that little box there. And this is just kind of taking a real dive here. And we're now more like 1,100 sites reporting. I know there have been some changes in terms of the vendor that's being used for wastewater sites. Not sure what all is going on there, but definitely don't like to see the number of sites reporting going down because this is a piece of infrastructure I know we were all hopeful would be increasing. But nonetheless, if you take a look at the red and orange, those are the sites that have increasing concentrations of SARS-CoV-2 in the wastewater. And overall, those are down compared to where we were in pretty much over the summer. And since the mid-September or so, it is lower. So there's something that we'll just continue to keep an eye on. But again, one of the things we're keeping an eye on is how reliable is this? There are a number of resources for wastewater in the post. So I would suggest that if you're interested in what's going on in your particular area, you look at those resources. Now, taking a look at percent positivity, this has been coming down since our most recent peak, which was August 26th. We're now at 10.2% positivity, and this is based on around 75,000 tests per week. The test positivity is still more than double where we were in June, but we are still heading in the right direction. And this is percentage of emergency department visits with diagnosed COVID-19 in the US. It's not coming down quite as quickly as it was before. You can see it's kind of, I don't want to say it's leveling off. It's still coming down, which is a great thing. This graph is showing us through October 20th, so that's great. Still only a few days old. The last peak we had there was in late August. So basically for September and October so far, we're coming down. Not crazy about seeing any leveling off there, but still heading in the right direction. So something we'll continue to keep an eye on. Hospital admissions, they're ticking down slowly as well. A little too slowly. We're still over 16,000 admissions for or with COVID-19, and this is for the week ending October 14th. But this is the fifth week in a row that we are kind of creeping down since being at over 20,000 hospital admissions per week, the week ending September 9th. So good to see us heading in the right direction once again, but this is still quite a lot of people in the hospital for or with COVID. And whether you're admitted for the COVID or this is on top of whatever else you have going on, this is certainly not a good thing. And of course, we are concerned about transmission that is happening in the hospitals as well. And for deaths, we finally can say that it seems as though we might be leveling off and hopefully coming down finally. We had 1,311 confirmed deaths for the week ending September 23rd, and there was 1,324 the week before, so just ever so slightly coming down. And so, as we know, this is kind of the last indicator to start coming down. So I certainly hope that we continue seeing this to trend down. But as a reminder, we did get as low as 473 weekly deaths just this past July. So the fact that we are about 2.5 times that number at this point is really, challenging at this point in time, where we say we've got the tools, we say we've got things figured out, but we're still losing over 1,300 people in the United States alone per week from COVID. So we still have a lot of work to do here. A lot of that work has to do with folks who are more at risk of a bad outcome, getting fully vaccinated, and also getting treated. We've gotten some news this week or last week, about the price of Paxlovid going up. I'm hoping that this is not going to result in lower uptake of Paxlovid, because really, anyone who has any kind of insurance should be covered for Paxlovid, and anyone without insurance should also be able to access it through patient assistance programs and things like that. But I definitely am concerned about all of these changes with the commercialization of the pandemic, the prices of treatment going up, the access being more challenging, and it being the main thing we have at this point to prevent hospitalization and death. And so this is something that, if you know you are going to need it, if you are positive for COVID, then this is something where you really want to know how you're going to get it and from where and what the process is in advance. Not much to report here regarding variant proportions in the US so far. We're still dealing with all Omicron subvariants. Let's hope it stays that way. As you know, our monovalent boosters are tuned against the XBB family. So that is primarily what we are being presented with at this point. So we'll continue, hopefully, with the no news is good news, but we will continue to keep an eye on this. So now I want to turn to long COVID. And so we know that we've talked about long COVID many times here, and how we know that long COVID is not just one thing. It is a number of different things that I think we're still trying to really fully grasp and understand. And there are quite a lot of different types of studies and research going on around long COVID. And so I wanted to just provide an update on some of the newer things that are going on in this space. Estimates about long COVID are still pretty much all over the place. It may affect 5%, 10% of people after they have a COVID infection. So, and that means each time there's a COVID infection. So still a lot to learn. There are so many different symptoms. Over maybe around 200 symptoms have been identified. And a lot of these have to do with what we were calling brain fog, or really neurological or memory related, concentration related symptoms. And this study was really looking at those cognitive symptoms, memory, and really trying to correlate it to a marker or some type of way to assess this by blood tests, and not only to be able to assess it, but also to be able to treat it. So that's why I think that this study is important. Even though it's not completely conclusive, it is really using a number of different types of evidence and data that kind of help to support a conclusion. And that is that for people who have these memory or neurological effects after COVID, that there may be a role of serotonin. And serotonin is a neurotransmitter. So it's basically a chemical that kind of helps neurons in the brain, so nerve cells in the brain, talk to each other. And serotonin also acts as a hormone, and it is involved with a lot of different functions of ours, like sleep and emotions and concentration. And this study that was published in the journal Cell did a number of different things. So one of the things that it did was take a look at different data sets about people who had long COVID. And they grouped them up based on the different symptoms that they were presenting with. And then they checked on different biomarkers in a subset of those patients that they felt represented the different symptom clusters. And then they compared those patients, they compared that biochemical profile of those patients with people who were infected with SARS-CoV-2, but who did not have long COVID. So people who recovered from their COVID infection and didn't have any residual symptoms left. And so they basically were comparing the biochemical profile of patients that had specific symptom clusters with those who did not have any remaining symptoms after SARS-CoV-2. And they found a few things. One of them is that some of those patients still had traces of SARS-CoV-2 in the stool samples, even long after the infection had resolved. So this is kind of supporting one of the theories about what might be going on with long COVID, that there could be persistent virus, at least in the gut. And so this was an interesting finding. The other thing that they found is they found a lower level of serotonin in some subsets of these patients as well. And I've actually gone over previously how there have been some findings that people with acute COVID have also shown reduced serotonin in the blood, and that was replicated in this study as well. The other interesting part of this study was that they did some mouse studies as well. And what they did here was look to see, first of all, how if they infected the mice with SARS-CoV-2 or caused sort of an inflammatory response with a drug that they injected them with. So basically, either way that they could get a drop in blood serotonin in these mice, they wanted to see what might be causing that drop. And what they found was that either the virus or this drug treatment was basically interfering with serotonin being produced in the gut. And that is the main place where where humans also produce serotonin. And basically, it requires the gut to absorb tryptophan, which is something that comes in our diet, like from dairy products, for example. And that tryptophan in the diet is kind of a precursor of serotonin, and it gets converted into serotonin. And so if you can't convert tryptophan into serotonin, then you could end up with low serotonin levels. And also, it seemed that the virus was helping to promote also an enzyme that breaks down serotonin. So, a couple different possible mechanisms here of how we're ending up with this lower serotonin level in the blood. And this is what they were investigating using a mice model. They took this a step further and they did some memory tests. So who knew? But you can do memory tests on mice because mice actually apparently gravitate towards new things. And so they basically were able to show that based upon the mice losing interest in the old things and gravitating towards the new things, or just keeping on thinking that the old things were new things because they have memory problems. So this is kind of, I'm oversimplifying, but this is kind of a way that they're able to see about mice and how they're able to perform basically memory tests on mice. So they were actually able to link the changes in mice's performance on memory tests with this reduced serotonin level. And they took it even further than that and tried to reverse the impairment. And they did that through a couple different ways, but both ways are aimed towards increasing the serotonin levels. So I mentioned tryptophan. So they tried supplementing the animals' diets with tryptophan, and they were able to help improve the memory. And this is thought to be because of the boosting of the serotonin levels. The second way that they tried it was through an antidepressant from the class that we call SSRIs. Those are antidepressants or selective serotonin reuptake inhibitor. So those also will boost the levels of serotonin. And so basically by inhibiting basically the uptake of serotonin means that you have higher serotonin. So by increasing the serotonin, they were able to reverse the memory impairment in mice, and that was through tryptophan or through the antidepressants in the SSRI class. So I think overall, this is not a complete slam dunk because there were some pieces where I think there's still some questions about what subsets of patients this is going to be applicable to. There was also some questions about whether the serotonin is it about serotonin in the blood or serotonin in the brain? I don't think we know the complete answer to this, but I do think that this gives some clues to basically point in a direction of where we might be able to study some potential treatment. I think we still have a ways to go to figure out which patients might be the ones to benefit from some of this. This is not a situation where you could probably just go out and take a bunch of serotonin and see what happens. I think that the way that they were approaching trying to boost serotonin levels in the brain by either increasing tryptophan or by using the antidepressants still need to be tested. So, but I think that this is really sort of hopeful in my mind because we're getting more clues, and they're clues we might actually be able to act on, and that we may be able to design some clinical trials to see if these interventions are going to work. And also, I think it's important that these may point to how we might be able to actually use these markers in the blood to say, okay, well, if you have these low serotonin levels along with memory impairment, then maybe we can focus the intervention on trying to address that issue. So I think we're still early, but I did think this was rather promising, partly because one of the things that this study kind of helps to do is bring together a few of the different hypotheses that have been proposed. And I've gone through a number of these in a prior briefing that is linked in the post. I kind of go through all the different proposed mechanisms so far for long COVID. And the sort of, I'll just call it serotonin hypothesis. That's not what they're calling it, but just for purposes of this conversation, the serotonin hypothesis kind of brings together a couple of these, which is always attractive. If we can help answer a few things with one underlying mechanism, it's helpful because it kind of helps to put things into a better model that we might be able to address. And that is that there's persistent virus somewhere, a viral reservoir somewhere. That is also that there is persistence of the virus in the gut. Also that there is persistent inflammation that could be leading to some of the symptoms of long COVID and or tissue damage. And also some issues around having some issues with clotting. So being more coagulable or having more clotting. And all of these things are related to the potential, the serotonin, kind of have a link to the serotonin piece. So again, not a slam dunk. It's not 100%, but I think gives us a lot of clues that we are going to see be pursued in the coming months. And the next thing I wanted to discuss is a clinical trial that is currently in progress near where I am locally here at UCSF. And it's one of too few, I think, trials that are going on currently for long COVID with treatment. So treatment trials. We have a lot of kind of basic research studies that are going on to try to figure it out. That's super important. But also, I think trying some treatments is just as important. And basically, based on that hypothesis that I just mentioned about SARS-CoV-2 lingering in somebody's body after they have an infection, that may be one of the causes of long COVID, that based upon that, this trial is using monoclonal antibodies. So if you remember, monoclonal antibodies are a treatment that we used to have available with some of our prior SARS-CoV-2 strains that were circulating. Unfortunately, we no longer have monoclonal antibodies available for treatment, but we still have those old monoclonal antibodies around. So the thought is, well, if we've got folks who were infected at the time of those prior SARS-CoV-2 strains, then maybe we can use the monoclonal antibodies to neutralize the pieces of those viruses that are just lingering around and help kind of tune up the patient's immune response to be more effective and be able to clear whatever lingering virus might be left. So it is a small trial of 30 patients, and I'm going to show you here on clinicaltrials.gov. And remember, you can come here to clinicaltrials.gov and look up all kinds of clinical trials, but here what I've looked up is long COVID, and I put in monoclonal because I want to see there's actually a few different studies going on. Some of them are looking at people who got monoclonal antibodies in the past and what that is, how that is correlating to long COVID. But the one that I'm referring to here at UCSF is actually doing a trial, and they are looking for 30 participants. I believe 20 of them will get the monoclonals and 10 will not. You have to have had your COVID infection before September of 2022. So that way, the strain that you probably had should be a good match for the monoclonal antibodies. And so this is a trial that is happening now. They're recruiting now, so it's worth knowing. If you or your patient or your loved one is suffering from long COVID, then it may be worth looking into all of the different treatment trials about long COVID. So, of course, the best thing we can do to avoid getting long COVID is avoid getting COVID in the first place. So let's remember all of our best practices around avoiding catching COVID or catching COVID again. To reduce the risk of getting long COVID. And also, we have seen, and I've gone over in a prior briefing, which is also linked in the post, that being fully vaccinated does also reduce the risk of getting long COVID, even if you actually catch COVID despite being vaccinated. Having been vaccinated reduces the risk of getting long COVID. There's also some suggestion that getting treated timely for acute COVID may reduce the risk. I think we still have more to learn here, but essentially we want to avoid getting sick with COVID in the first place. And certainly we know that when folks have more severe acute course of COVID, that there's also a higher risk of long COVID. So everything that we can do to reduce getting it or reduce the severity, which of course includes vaccine and treatment, all of those things are going to work in our favor in terms of reducing the risk of long COVID or post-COVID. And remember that for those who do need treatment, that it needs to be started as soon as possible, ideally within 5 days. These are the different outpatient treatments. Paxlovid is still considered first line just about everyone, unless there's a real reason why you can't have it. Remember that in order to get treated in time, you've got to get tested in time. So this is something to plan in advance. Where are you going to get treated? Where are you going to get tested? And if are you someone who is going to need to be treated, this is something to discuss with your physician. But basically everyone 50 and over and everyone with underlying conditions, the list of those is quite extensive. It's also linked in the post. So in summary, I think we are in a place of seeing signs in the US and most places in the US of trending down of SARS-CoV-2 with decreased wastewater concentration and percent positivity, and finally starting to see a slight downturn in deaths, still seeing too many hospitalizations, over 16,000 a week, still seeing too many deaths, over 1,300 a week. So this is just far too many hospitalizations and death. So we're definitely not out of the woods. And we anticipate, I think everybody anticipates that this will be going back up. Hopefully we can mitigate that a little bit if folks will get their most updated booster. Those are the monovalent boosters. We now have Pfizer, Moderna, Novavax. You got three great choices. I went into detail on the Novavax last week if you're interested in taking a look at that. And also, we know that our flu is just starting to pick up now. And so we know that we're getting ready to head into what we would call respiratory virus season. So it's going to be not only COVID, but also flu and RSV to be keeping an eye out for. So that's why we want to keep up our best practices to prevent the spread of respiratory illness and prevent outbreaks. And we know that no one layer is foolproof. So we're going to want to implement layers of protection, especially as it relates to COVID, because we know how contagious COVID is, how it can cause outbreaks, how it can cause super spreaders. So in addition to staying up to date on your vaccinations, we want to wear a high quality mask indoors, like an N95, a KN95, or a KN94. Make sure it is fitting you well. It has a good seal. And you're going to want to ensure that you have good indoor ventilation and filtration. And whenever possible, gather outside. Outdoors is almost always safer than indoors. Remember, even if you had COVID once and you did okay, that's not a guarantee about next time. Better to avoid the next time. If you've had it twice, avoid a third time, and so on. There is mounting evidence of the cumulative effects of repeat infection. And there does not seem to be any limit to the number of times you can catch COVID. And after COVID, we're seeing a number of different impacts that could be affecting almost any organ system in the body. We are seeing new onset diabetes or worsening diabetes. We're seeing blood clots, heart attacks, and strokes, memory issues. We're seeing new onset asthma or worsening asthma. Of course, this doesn't happen to everyone, but it happens in some subset of people that we still cannot predict. This could happen after your first infection, but maybe after your second or third. Again, very unpredictable. So if you don't feel well, please stay home and rest. Not resting's also been correlated to more prolonged effects or even long COVID. If you're someone who should be treated, if you catch COVID, know that in advance and have a treatment plan. Also have a plan for isolating, have a caregiving plan. Who's going to take care of you and who's going to take care of the people that you usually take care of? This should all be part of your plan. If you do test positive, please test negative to come out of isolation. Test negative before you go back around others. And if you don't have a primary care provider, please get one. Know how to reach them before you need them. And let's remember to be active, get your exercise as long as you're not sick, eat a balanced diet, incorporate fresh fruits and vegetables and whole grains, and avoid those sugary drinks. Consider a multivitamin supplement, maybe with some vitamin D. Let's get those baseline labs checked, get your blood pressure checked, manage your stress levels, and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us, and we'll see you again next Tuesday at 10 a.m.